You know, Eshowe is a good example of success.
We would go to the communities, find people in their comfort zone, whereby we had about 84 community healthcare workers which were going in the household providing education on HIV, TB, STI, then offer a pre and post counseling for those who would be willing to be tested for HIV in their comfort zone, which is their home. And those who would test positive would also be linked with the nearest facility. And for us, before we do that process of doing door-to-door, we had to engage with the community leaders, which is Izinduna, Amakosi, and ward councillors, because as maybe when you were driving coming to Eshowe, you saw that this place is quite a rural setting, so it is more dominated by the leadership, the traditional leadership. And then while we were engaging with them, we also identified that the Eshowe and Bongolwane community is still also believing in the traditional healers. And then as a project, we took an initiative to say, okay, let's engage with those traditional healers to educate them, to give them a better idea of what is HIV and what is TB. Then with us doing that, I would say it also helped us a lot, because when the community would go to the Isangoma or Inyanga, the Inyanga will, before they start their process, they would also encourage the patient to say, have you tested for HIV? Because when you look at the symptoms of Uktwasa, it's slightly the same with symptoms of TB, because a person will lose weight, and whether if unedlozi or TB, you will lose weight. And also when you are HIV positive and we are maybe on stage 3 or stage 4, you will be losing a lot of weight. So those are the things that really helped us, because we worked with traditional healers, meaning that the team that was providing door-to-door in the household, the traditional healers would be able to link the patient who come to their household for any consultation to say, okay, there's this community healthcare worker who's working locally here, who's providing HIV testing. If you want to be tested for HIV, you can go and get tested.
Ubuhlobo bethu no-MSF buhle kabi, and ekufikeni kwakhe kube negalelo esibonayo elihle lokuncipha bokufa kwabantu, nokukhuluma nje ukuvuleleka emphakathini. Sisakwazi manje ukuvuleleka ngoba u-MSF usifundisile ukuthi asivuleleke, sikhulume nabantu, sibaxwayise ubungozi bokufela ngaphakathi. Uthi uma ugula vele uyagula, kodwa futhi uyakwazi naye ukuthi engakucebisa ukuthi uma ugula kanje ungasizakala kanje. Yilokho nje esingakubeka phakathi kwa-MSF. So phatheka kabi uma sihamba e-MSF, ngoba kusho ukuthi kube ngasekho abantu abanjani abakhuthaza umphakathi ukuthi uphumele obala ukuze wazi ukuthi usizakala.
These 90s that we keep talking about, it says, first 90 is talking about the population of Eshowe. It says they've tested for HIV, they know their HIV status. Be it they are negative or they are positive, it means they have tested. It means we are left with only 10% of the population who have not yet tested. And then the second 90 is talking to say, out of those who were found to be HIV positive from the first 90, they are linked to care. It means they are accessing health care, they are getting treatment, they are on ARVs. And then the third 90 is saying those who were HIV positive and started treatment, they are virally suppressed. That's why we are sitting at 95.
That's a grasshopper or locust. And
Out of
all houses
section.
are pretty much
The same.
standard. I mean, they all look the same inside. Yeah. It's all done the same. And this is our most. That all those butterflies with the names are the children who have been in the care family that have died of HIV. And so this is our story of death to life. In '93 as a hospice, specifically for children dying of AIDS. And so it was much less built up here. There was nothing around us. It was an ideal place for children to get dumped or left when there was such a huge stigma around HIV. And not, not understanding HIV and, just don't tell anybody, let's just get, goggles leaving children. So a lot of our older children, we battled to trace family because some of them we have had no records of. So they came here and they were suddenly given proper foods, they were given love, the illnesses that they got because they were more susceptible because they were HIV positive were treated properly. Of course then ARVs came on the scene and they started getting ARVs and so then they didn't die. And then we said, well, what do we do with these children now? And that's how we kind of evolved into a children's home.
Homework times, tutoring times. We also use it for different activities.
So we did have a fully equipped clinic at one stage that even had x-rays and stuff that was running for the community. And then, the challenges that Priska spoke about earlier, that isn't happening anymore. So we still have the actual building and we still have the clinic and that's where our kids go. And we still got a pharmacy there. But just in terms of the struggles with, on the medical side, yes, it's the under-resourced clinic in the area really is the issue. So we obviously drive out further and like a lot of the children, we've got some children that have physical challenges as well. So there's a lot of OTs, physios, speech therapists. We make trips to the hospitals and clinics, mostly Pietermaritzburg, pretty much almost every day of the month. At one point, unfortunately, the clinic said they couldn't any longer give us any ARVs. Reason basically being was that there was such a high number of HIV positive infected children and they just didn't have the resources. So fortunately, having a little doctor and having somebody who was a strong voice for us, it made it easier. And we were like, well, we have to, and we pressed on. So now we don't get them from the local clinic, but we get them from the hospital in Pietermaritzburg. So we are getting our ARVs. We still, unfortunately, are not getting the blood CD counts done, so that we're still having to find our own finances for. And then, to have the kids tested or retested if we're not sure of their status. Medication for other things like mood disorders or epilepsy. We've got a little child here who's got a heart condition. And then other children who've got other physical needs. All that we do as much as we can through the state. But there's a lot of extra stuff that we just have to fit the bill for because otherwise they're not actually going to get the care that they need.
If you want to be real, it's like every month we pray that we will be able to pay our salaries and finish all the month's kind of end things. And that's been going on for quite a while because I've been here for quite a while. So there's a lot of prayer and a lot of, okay, how is this going to work? And we've been kind of, sometimes we pay salaries late, and that's a challenge for obviously our staff as well because they're also dependent on us being able to pay. And so there are little things, we cut back quite a bit on food, not like that they don't get what they need, but you see like let's say eggs or something, we're not able to provide as many as they maybe could use. We keep it all very minimal. So, and those are challenges that we really like. It would be great to be able to kind of get that sorted if we could. So we keep it very minimal, and we always make sure that the kids are fed well, before, that's why we are late with paying salaries, because we make sure that the kids are the priority.
Yeah.
And then we pay. So that's like, we know the food and the things for the kids first.
Talks about a lack of resources and a lack of money and a lack of, and as I said, there will always be a challenge because we'll always strive to continue to do better. There is actually money out there, but there needs to be a system in place to work with donors, to source donors, to keep donors informed about what we're doing. Because it's all very well donor coming in and saying, oh, we can give you blankets or we can give you clothes. That's great once off, but we need to develop longer term, more sustainable funding relationships. And so for me, that's my focus here, is to how do I develop a strategy for Lily that's going to make them self-sustainable.
Sizwe inkinga zabantu, siprofile futhi emzini nabantu, sibuze nangokugonywa kwengane, nabadla uchronic, any kind of chronic. Kubibona ke lapha HIV and AIDS. Iyona le yaka HIV. Ngoba lasalo sibe nabo abantu kuthiwa bayalanda amaphilisi sinikwe eclinic kuthiwa siba trace. Siba trace ama defaulters siwathola. Kodwa masuthola nje ngikutshela 1 ingxaki yokuqala abantu abasebenzi. Bake basola imali ukuthi bawalanda eclinic.